The case. A female patient 73 years old with yellowish discoloration of the skin and the sclera. ERCP was done in 11/2019 showing distal CBD structure with filling defect inside CBD with insertion of plastic stent 10 French 10 cm. CA and CA19-9 are normal. Patient is for Spylgass.
Okay, you may give me the ball tip catheter.
We are with you, Mr. Jubier.
Good afternoon.
Good afternoon.
I have the pleasure of working under the supervision of my friend, Dr. Repici.
Good afternoon,
and with the team here, Salman, Ajel, Anish, and with the anesthesiologist, the radiologist. So this is an interesting case because the fluoroscopy that you have seen was taken, the MRCP was taken 6 months ago, and we have a new MRCP which suggests that this patient might have an extension of a tumor. So we just have removed 2 stents, and you see that this patient already had a sphincterotomy before. So I'm just using a ball tip catheter which has been flushed with contrast, not yet, so push contrast. Always flush your catheter with contrast before starting the injection. No, leave the wire in and flush your with contrast. It's a 3-lumen catheter, no?
No, it's not.
Okay, very good. Okay, and then we will go inside the bile duct. I will just...
2 stents migrating inside common bile duct.
Okay, that should be in this direction. Let's see where the guide wire is going. Flow, please. Okay, advance the wire very gently. Okay, the wire, it's going inside the pancreas. It's the pancreas.
Is it pancreatic?
This is the pancreas or not? I'm not completely sure. What do you think, Sandro?
Probably right. It's the
Can you inject a little bit?
Yeah.
Flow. Yeah. So I don't see very well the fluoroscopy, which is far away.
You know, it's not a triple lumen catheter, it's a single lumen, so they are injecting,
yes.
The contrast is going out.
Okay, do you have a sphincterotome with a 3-lumen where you can inject and pass a guide wire?
Okay, this is good.
Dr. Davier, are you injecting contrast now?
I'm just waiting for having the right catheter. So I will try to inject contrast and to go to the bile duct. You see that there is some blood coming out of the bile duct, which is never a good sign when we have a suspicion of tumor. As I told you, I have just removed the 2. No. Then we will just go inside this opening. Let's see, this should be there. Or maybe there, yeah? That's better. Flo, advance your wire. Okay, where we are going? We are going into the bile duct. And then we will make an injection there. I'm probably getting older, but the view by the flow at this distance is not easy. So I hope that you have the fluoroscopic image, and I hope that the fluoroscopic image is better in your side than in my side. Can we inject a little bit more? What's that? Is that a stone or is that Can you focus on the fluo, please? And okay, inject a little bit more. Okay. So here we are. So it might be a big stone.
Yeah, we're seeing some filling defect, and just at the hilum, right?
Yes, below the hilum there is something abnormal. You see that my
Yes,
my
we can see the
sphincter-
fluoroscopy very good now.
So pull back the wire a little bit. Fluo, please. Fluo, please. Okay, thanks. Pull back the wire, then try to go more deeply inside the intrahepatic duct. Advance the wire now.
Probably there is
Advance the
also a
wire. That's
stone-
very good. Go, 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 go,
there
go,
is
go.
also a stone on the.
Excellent. You think it's a stone?
Yeah, probably
My-
there is also another stone in the left
Yeah.
side of the.
It might be a stone indeed.
And
Then we will inject again. So this is a relatively good
Then
news.
now it's a little bit better. You can have a look at the.
Yeah.
there are a few
Yeah.
intrahepatic
Yeah.
also filling defects,
Okay.
right?
Yes, we will probably, this might be because today is Christmas, so the spyglass is for free, so we might use the spyglass to see what happens. But I will put the spyglass over the wire in this case because I'm afraid that I will be in trouble. So leave the wire in place, okay? Okay, very good. And then we will use this very nice endoscope from Boston Scientific, which is the spyglass. There is indeed a lot of blood for a stone. That's something which is. This is indeed this is the reason why I don't try to get it with a Domia basket immediately, and I would like to have a look because the fact that we see a little bit of tissue, that there is some blood. But by the way, the blood might come from the fact that initially when I took the first hand with the snare, I had a little bit of mucosa also.
So, Dr. Davier, we
may-
don't need to complete the ossification of the common bile duct to its distal end.
We don't need what?
We don't need to do a complete ossification of the common bile duct to see the common bile duct completely down its distal end.
But we already saw all the proximal part of the common bile duct, and this lesion, which is in the mid part of the common bile duct, so I don't see any reason for having more injection than that. We already had a lot of injection, in fact. So I'm just very gently advancing the spy. And I will ask you to give me the spy image for...
Professor Davier, do you usually do it over a guide wire?
Not always. Most often, especially when I have just to enter a large common bile duct, I go directly with the spy. In this case, I prefer, because you have seen that it was not so easy to pass around this. Pull a little bit. You don't need the spy view now, because we don't see anything by the spy. I would like you to have the fluoroscopic image. At the régie, yes, that's better. Fluo. You have to pull the wire a little bit. Okay, you see that my catheter is coming. There is a little bit of tissue on the catheter. And I will try to advance it inside the bile duct. Yes, here we are. May I have the image on the fluoroscopy?
The wire is deep inside.
Yes, the wire is deep inside, in fact. So I will flush. Do you have the flush? This is the flush of the... Okay. I have a position which is not ideal. This is probably my fault. Can you focus a little bit more
On the scope?
on the scope, distally?
There. Yeah. Would you like her to do something on the wire or no?
Not yet.
Not yet.
I just try to have a position which is a little bit more below the papilla. Now you can give a little bit of tension on the wire, like that. Very good. And then I will try to push a little bit more the spy scope. That's better.
I think
You
you
see?
advanced. You're inside.
I had to use a semi-long position there to see where we go. And then let's try to see what we see with the scope itself. Not many things. There. We should be...
This is probably the legion that is compressing, right?
It doesn't look like a stone, huh?
No.
At least not immediately.
Yeah.
Then we have
Now
the-
you're probably at the mid CBD, yeah, approaching the hilum.
Here I'm in the hilum, probably. Okay, here we are. It's atypical in any case.
Yeah.
So we see the wire, we see the common bile duct, the normal wall there. Sure, yeah, okay. So I should be a little bit above the lesion.
Yeah. So yes, this is the legion, yeah. Where?
Not yet. No, not yet. Stoi.
Yes, you see this bleeding region, it doesn't look like stone, huh?
No, not at all.
It looks like a mass.
What do you think, Alexandro?
So I think you're right. I cannot see any stone. I cannot see any fragment. That's also very suspicious.
Yeah.
So we need to pull back again a little bit and probably we make it a diagnosis. But as we have seen before, there is something very unusual.
Yes, you see that this bleeding tumor, so it might be like a mucin, an intraductal mucin secreting tumor. I'm pulling back very gently. Yes, you see these fragments into the bile duct
Look at the big
are
vessel.
very suspicious, especially there. Maybe we can try to take a biopsy, but we see this
Can
lesion.
you pull back just 1 millimeter, so
We-
probably we have a better look to that.
We see this lesion
Okay,
bleeding a
okay.
little bit.
Yeah.
Professor Jack, I think the image is not clear enough. Yani, is there any technical error of the procedure?
Anything what?
It's not clear.
What we see from the procedure
Okay,
here is
now
that
we can see better.
we are just in front of the lesion. You see that the lesion is slightly bleeding.
لما في bleeding كده.
So it might be a tumoral structure. This patient has no portal hypertension, I suppose.
Dr. Davier, excuse me, we will
There is definitively no stricture.
Dr. Davier, we will let
will
you
take a
now,
biopsy.
and we should go to another case and back to you again.
Yes, just to tell you that this is probably the most important part now. When we see this lesion which is bleeding and which is clearly a tumor there, then we will sample. Huh? So we will take a spy bite. We are still fighting with the diagnosis in this patient. We are in the mid part of the common bile duct. You see that we have this irregular structure there, which is definitively not a stone, but it's also atypical for a tumor. We have already done a few biopsies.
How many biopsies you prefer to take from this patient?
I take as many biopsies as I feel needed. Open. 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 You see that I'm using the spy bite, which is a very nice close, a very nice biopsy forceps, which is only 1 millimeter in diameter to get this sample from the bile duct. Flow, please, yes. And I try to continue to look at the bile duct. What I will do now before you... I will probably also, after taking another biopsy here, I will also inject a little bit of contrast to understand what we do.
And now we have an explain for the hemophilia we noticed at the first.
I'm sorry?
Now we have an explain for the hemophilia that we noticed at the first, the blood coming from the papilla.
We don't see so much blood coming from the papilla, but we see blood coming from the choledocus inside. You see that this is on the cholangioscopic image that you have to the blood, not on the papilla. The papilla is the image that you have in front of you is not the papilla, it's the choledocus. Huh?
Turhani, you have question, please. After histopathology, is there any indication to use the Spylgass as a therapeutic maneuver for radiofrequency ablation?
There's a question. Do you see any role for radiofrequency ablation via Spyglass?
No.
Absolutely not. We don't know what is this stuff.
I don't know what means radiofrequency ablation by Spyglass, but
It's here.
there is definitively no role, yes.
We have a question from the floor now.
I'd like to ask about what are the features of malignancy we can see during the Spyglass.
Flo, please. Okay, here we are. Flo?
Dr. Devier?
I'm sorry, but I'm looking at what I do. So if my colleague can answer.
The question was, what are the features suggestive of malignancy?
So there are a couple of features that we should consider. The first one, when Jack is able to properly look to the mass, there are very thick vessels. These are absolutely abnormal in the normal bile duct. And also there are projections of tissue. We call these similar to villus appearance. And now here.
But we can see projection in a previously inserted patient also.
May I have a look? Maybe we have a stone that we have missed from the beginning. So this is useful to have a double look and to be several.